informative lecture, and your lecture was very informative in the sense that there are a lot of biopsychosocial issues related with the reimplantation and again the post-operative care, and there are a lot many things to consider about carrying out these procedures. Uh, I would like to thank Dr. Palak and Dr. Mustaqim for being patient for this much time, taking out taking this time out of your busy schedule. Now I have to open the floor for questions so that our presenters may interact for the queries. So please, Dr. Asif, can you carry out the question?
Thank you, Dr. Ahmed. Thank you for moderating the session for us, this virtual session, which is a new experience for us as well. Now, I'm going to, first of all, I want to thank all my participants, especially Dr. Falak Sher, Professor Mustasan, who obviously have taken their time, very busy time, early morning as well, to be part of our webinar. Now, very comprehensive lecture, first given by Professor Mustasan on flaps and its application in wound closure. Really, I would say, a thorough, very thorough described lecture about the principles of the flap surgery, all different sort of flaps, concepts of angiosome, and the details. And it will be really a very knowledgeable lecture for our residents, especially plastic surgery residents, plastic surgery doctors, and even for our general surgery or general doctors as well, as they would know about the applications of plastic surgery in the wound closure. And then I would appreciate Dr. Falak Sher, who has been very well known in our circles as a very renowned hand microsurgeon, and really he's shown remarkable results with his replantation. A very, very nice long lecture as well, but really very interesting lecture. And he really touched even every aspect of hand replantation, microsurgery, almost very particular details of all that. And I really appreciate his results as well. He has shown some of the results as well at the end of his talk, which was really eye-opener for us as well. Then I touched, actually, my lecture was about the hand transplant. So this is just like, because more like introductory, sharing my experience when I was in Louisville doing a hand and microsurgery fellowship. So just wanted to open an area. Obviously, this is not the procedure we're doing here. It's only done in the first world or highly developed nations like America, maybe in part of Europe, they are doing it not very regularly. So the cases are very few and far between. But just want to touch upon that in modern era, there is an option available for patients who have lost their limbs. Now I want to have open the discussion open, and I would ask Professor Mustasan that I might, just to open the discussion, I just want to know, taking his vast experience of teaching as well as being the head of one of the biggest unit, that for the residents or all the participants, while harvesting flaps, what he thinks, what will be the key points for the surgeon to take care.
Thank you very much, Professor Asif, for such a wonderful event, and I'm really impressed as always by the case series of Dr. Falak Sher and by your lecture. And I think it was an excellent experience for the residents, looking at the basics and then moving forward to the nice and extraordinary cases presented by Dr. Falak Sher and then by yourself describing the hand replant. As regards your question, regards your question, I think most important thing is that they should know the anatomy of anatomy. If the anatomy which we have been taught in routinely is not what we actually need, so they need to do the details of the anatomy, the smaller vessels, the angiosome, and doing dissections if possible. So I think the basic thing is knowing their anatomy, knowing which areas they have to be careful around the pedicle, their locations, and their anatomical details. And I think apart from that, other basic techniques of soft tissue handling, because if there is a dictum that if you respect the tissues, tissues will respect you. So knowing their anatomy, knowing their limits, and before going into any new flap, they should try to have someone supervision, so that they should know the basic steps. And most importantly, I think, is that they should know where they have to take extra care and where they have to spend extra time. That is most important part of flap raising. So again, I think coming back to the square one is the knowing their anatomy, knowing their limits. So I think this is the key message I would like to
No,
extend to
Professor
the
Moses,
residents.
with you have to answer a very nicely taken answer. Now, my next question will be now just follow up that. What do you think will be the role of flap training workshops? We have, I understand, one of the very main trainers of plastic surgery. We do have microsurgery course, and almost Professor Mozum Tara do it very regularly for almost 10, 12 years. But what do you think about flap training workshops? We have only few, which I understand, maybe I'm wrong here, so I'm new in here. What do you think should be the flap training workshops, where cadaveric or non-cadaveric, in training our residents, especially about this all sort of flaps, whether free or the pedicle flap?
Yeah. So I think these flap workshops are a regular feature of any training program, and there are many offered around the world. We have been part of quite a few these flap workshops conducted under the banner of Society of Surgeons. Then one was held at Multan, Nishtar Medical University. So there have been quite a few workshops on flap courses. So, but the basic problem with those courses or those workshops have been that the quality of the cadaver that we get, they are usually mummified, they are not optimally stored, or they are not fresh cadaveric bodies. So that is probably one of the limitations, but still I think that should be a regular feature. And one of the suggestions in College of Physicians and Surgeon Pakistan faculty has been to organize a regular flap course like the one microvascular course being held at Jinnah Burn and Reconstructive Surgery Center. So I fully agree that we should take lead and we should try to organize flap courses regularly with whatever cadavers or dead bodies are available. But that is one of the limitations here in our setup, that we don't get the fresh cadaveric bodies. But still, I think it's worth doing, and we should encourage such courses.
Yes, thank you, Professor Moses. Very nice discussion. And now I just want to one question actually with Dr. Falakshare. You are on listening. Is what we have read through your lecture. There are a few questions I have come across.
You most welcome.
Yeah, you mentioned about dermal implantation, one of the technique in the venous congestion, in controlling the venous congestion. The dermal implantation. One of the few you listed 7 or 8 techniques we should do to prevent or to treat venous congestion in the replantation. I don't understand what you meant by dermal implantation in your talk.
Thank you very much for taking me on board for question answer session. Dermal implant technique is used whenever you are unable to find suitable veins. Veins are not available, and you're not able to do that. Then you can deepthalize a rim of skin from the amputated part, and you can shorten the bone, and you can bury that de-epithelialized dermis under the proximal part, under the skin of the proximal part. This way, you are going to increase the connection between the recipient part and the amputated part. And this dermal implantation may help in solving the problem of venous congestion over a period of time. Within few days, with 1 or 2 days, you will be able to get connections between the proximal skin and the distal deacrylized buried skin, and this way the problem of venous congestion can be tackled. This is one of the way, and this is used for very minor parts which are amputated and which the veins are not available. And this is we are
Thank you.
using for we are using this technique uh, nose reconstruction as well. Whenever we are going to reconstruct like L of the nose from the root of the helix of the ear, we take a longer skin from the ear and we deoccluize it and we bury it under the nasal skin. So that's how we increase the chances of survival of the reconstructed part.
Okay, fine. Thank you. Thank you, Dr. Falakshir. That your lecture was really a wonderful lecture. It's a lot of really mesmerizing pictures you have shown, results as well, especially a few of the cases in which normally we are avulsed hand, which is taken as a contraindication for replantations. So
But that is
over
I
normal.
think every amputation nowadays is not none of the amputations are contraindications. It depends upon your level of comfort, how much easy you
Okay.
feel
So that,
going for.
now that's why my next question is actually because I want you to divulge on it in detail. That what will be the selection criteria now for candidates for replantation? Now, because in standard teaching we teach that when a single thumb is there, multiple digits, which is non-dominant, we don't do that. But now, what do you think, especially with your expertise and the very specialized center we have?
I think nowadays the
What
only
will be
limitation is
the
either
selection candidates for replantation? How will you, how now you describe it? That which candidates are we should go for replantation, surely, or try to replantation.
strong contraindications nowadays are only the crushed the amputations having an element of crush, and the avulsions are not nowadays a contraindication. The only strong contraindication is the number one is the this element of crush injury in the amputated part, and number two there is an element of segmental injury. There are multiple the injuries are at multiple levels. Even people are doing nowadays replantations in which they do reconstruct, they do replant multiple segmental level amputations, and that even that now is becoming not becoming a contraindication. Rather than people are able to do that, they are able to repair multiple parts. And I think the only contraindication which remains is that the tissues are badly crushed in such a way that they are no more usable. Otherwise uh, all other amputations in which there is no element of crush can be taken as a challenge for replantation.
Replantation. Fine. Professor Mostesan, what is your take on that? The selection of the candidate for what are the if you ask president if you are explaining in the exam what they should ask the what are the indications for replantation?
I think what we expect from the candidates in the exam that they should know the standard indications, the standard contraindications or relative contraindications, and in addition to that, if they say that in experienced centers or centers where expertise are available, I think the avulsion has always been a relative contraindication, and the reason for it being relative contraindication is that that there are cases where it should be attempted. But for exam candidates, I think we should expect them to know the standard answers, and above that, if they say that these are indications in specialized centers, so I think that that is equally acceptable. And I totally agree with Dr. Palak Sher that with increasing experience, I think, and with the young lot coming up, they should try to attempt each and every replantation, except that there are absolute contraindications, like and they should always remember the dictum that life comes first over the limb. So I think, keeping in mind these few things, and with all the expertise available, the indications are expanding, and they should now be moving more away from the relative contraindications and saying that these are relative indications. So probably that should be the way they should answer in the exam.
Thank you, Professor Sesson. Thank you. That's very really nice eye opener for our resident as well, who preparing for exam, because sometimes it is a very difficult preposition. Because we give patient a hope that we're trying to replant it, and at least we have to tell them as well that there is a risk of, obviously, with a difficult avulsion injury, the risk of success rate is very much, not as much as should be the other cases. Now, Dr. Falakshir, now I want to ask you another, especially with your lot of experience in replantation and microsurgery, that when you perform replantation, what do you think is the single best factor we keep in your mind while performing replantation? Tricky question, but I know you are a big surgeon, so you can ask that. Single factor you keep in your performing replantation that's there is my yeah.
Can you please repeat the question? I could not take your question.
Can you hear me?
I could not understand. Understand.
While performing replantation.
Okay.
Can you hear me now?
Yes,
while performing replantation, what is the single? If I ask you, what is the single most factor in your mind that will lead you to success of that replantation while performing it as a surgeon? That this is going like that. Okay, I'm going to have a successful result. In back of your mind while performing the replantation, or this like very sort of very complex, difficult replantation.
Right. I think if you are able to the availability of the artery and the veins, especially the artery, I would say. If you are able to catch hold of the good nasal-visible arteries at replantation, then I think, and the patient is well in time, ischemia time also matters. Then I think there's then even if there is a large arterial gap in between, we can manage that at any cost. We can put in arterial. We feel easy that we have got an nasal-visible arteries, and then we can inert to anastomosis them if they are not primarily anastomosis. We can always go for putting interpositional venous graft, arterial grafts, or sometimes we can go for the flow-through flaps if they are indicated. So having good access and exposure of the arteries at the replantation, and then we almost become sure and certain that yes, we can do that. So availability of nasal-visible arteries, especially, is one good hope at replantation, that yes, we have got hold of the arteries, and now we can go for it.
What do you think is mostly the cause of failure in the replantation? If it fails or failing replants, what is your experience? I'm just trying to share I want to get opinion from your experience. If a replant fails, is mostly a venous problem or it's arterial problem?
Most of the time it is the venous problem, because arteries have got good pressure and they are less likely to fail, and the veins, they are low pressure system, and very easily chokeable, very easily compressible, and even sometimes compressed by edema only. There's no other compressing factor except for edema. Even the soft tissue edema can slow down the venous flow and can lead to venous obstruction and thrombus formation.
And
so
what are your?
We be very, very watchy about that.
Okay. And what are your normal donor areas for veins? These donor veins for vein graft, where you normally take it from that? From the surrounding area, or there especially?
Most of the time we take from the surrounding area. We can take from the wrist, from the forearm, we can take from the arm. Because this becomes, in this way, this becomes very easy and quick and quite accessible in very short time. You don't have to prepare other region for harvesting.
Okay. Now, Dr. Fletcher, you have any experience with the foot replant?
Yes, we have done a couple of foot replants at General Hospital. That is equally rewarding. I think that is equally rewarding. The only problem in foot replant is that is easily replantable, sometimes even easier than the hand replant. But the only problem is problem at getting good bony union in the lower limb, because there is a weight bearing bone. The bones are weight bearing, and then you must be having very reliable bone union. And most of the time, if we have problem, that problem is related to the union of the bones. We do get some non-unions in that, and we most of the time, if we have to revise it, we have to go for revision of the bone fixation.
Okay, and what is the sensory recovery in these cases, or motor recovery? Obviously, that will be an effect on that. I know hand, I have a lot of experience actually in hand, but I never seen the sensory recovery in the foot replant. If it is too proximate. Motor and sensory, both things.
Okay.
Sensory was more sensory. Motor,
yes.
yeah.
If you are able to,
at least sensory
is quite good. Sensory recovery is quite good if you are able to have a good repair of nerves, and if we have got a good end-to-end neurography, then the sensory recovery is quite good, provided you have done primary repair. And sometimes there is a nerve gap in between. Then you have to then there are two options. Number one is that you go for primary nerve grafting, or you go for you leave it and go for you tag the nerves and you go for the second time, and then if, once your hand is stable, replant is stable, then you can always go for secondary nerve reconstruction by putting nerve grafts at a later stage. But if you are able to do primary nerve end-to-end nerve repair at the time of primary replantation, then the recovery is very good, quite normal, I think.
Thank you, Dr. Fletcher. Now, there's one question for Professor Musesan. Now, the lecture I given on hand transplant. Professor Musesan, what do you think? Is there any future of hand transplant in Pakistan?
So I think with more and more advancements in improving the quality of life instead of quantity of life, people are moving towards improving the quality of life. I think what I foresee is that not in near future, but in I think in maybe decades time, that there would be regular hand transplant services here, because still we as a nation are struggling to improve the quantity of life by renal transplants and by other vital organs. But definitely the quality of life has to be improved, and with the more and more options coming up for this immunosuppression, I think there would be hand transplants would be done in future. But I don't see in near future, because there are many ethical issues. There needs to be a lot of legislations regarding the donation of the organs. We are still not able to get even the donation of the skin. So there needs to be a lot of work done. But having said that, I'm optimistic about this service being started, and maybe not in near future, but definitely.
This hand transplant is totally cadaveric transplantation. Cannot obviously in renal there is obviously the live donors are there. In liver there are live donors. Heart, lung we are not started. So this is unless we start a cadaveric transplant program for even kidney, liver, and hand transplant will just come as part, because in obviously in Western countries, whenever they have any cadaveric donor available, These I still remember the one I was involved in bilateral hand transplant. The guy they took for the hand, both they amputated at the level of above elbow. That guy have donated his lung, liver, both lungs, his heart, his liver was all being donated at the same time, while his limb were taken for bilateral hand transplantation. Obviously, the good thing about this hand transplant is the surgical part is not a problem, because mashallah our surgeons are doing a miraculous microsurgery job. So technically problem is not there. Obviously, I know every big unit is capable of doing hand transplant. It's just like a replant at a level of, say, wrist or mid wrist or upper forearm. But the problem obviously comes with the teamwork, especially the holding of how to take there has to be central, that's this mechanism of identifying the donor and then taking their a very obviously specialized system to make sure that the donor is available at times on the field, on the hospital. There is a list of donor available, and technical, it's not difficult. It's a 10 to 12 hour surgeries, especially to replant structures. And even I know with both microsurgeons, they know replantation doing at this level of mid-wrist is not too the problem, because the arteries are bigger. So even technically is not much issue. Problem comes with the chemotherapy or to prevent the rejection. Now, the good thing is that with latest they have got single dose therapy, which has to be used for a year or 2 years, and then they can give rise to lifelong immunity. So a lot of better drugs are coming, which a lot less side effects as well, especially maybe expensive drugs actually, but that may help in obviously all types of transplantation. Because even in England they started hand transplant very late, because as mentioned, ethical issues, which were the still in British politically very correct people, they were very late in starting the hand transplantation, while America and China, they took lead on that. Now, Dr. Falksher, what is your opinion about the hand transplant? If you foresee any way
I think
in future?
There are two issues mainly related to it. One is the quality of life and the risk to the quality of life in the recipient, because until unless we get good control over the quality of drugs, I think no one will be brave enough to offer the transplant, because this way, until unless we are having good drugs or immunosuppression which are not going to compromise the quality of life, neither the surgeon nor the patient will be comfortable at doing that. And the second issue is to convince the people about donation of their hands at near death or after death. And I think this becomes one very important religious issue. Until unless our religious scholars they are not convinced about this issue of transplant, people are not going to, because majority of the people, they follow religious scholars for organ donation, and they follow their sermons. And until unless they are convinced to go for approval of this transplant issue, people will not be taking interest into the donation of the organs for transplant. So I think these are two issues. One is the having good control over immune suppression, and the second is to convince our religious people, religious scholars, for making people aware of this transplant and for allowing this.
And also, I think definitely there will be a problem with the Nadra as well, identification problem, because the handprint will be different now. As a patient has been
Yeah, that is another issue, but that is a relatively less challenging issue.
Big Nadra
That
identification.
can be tackled
Somebody else crime maybe is a dead body, that person has committed crime, and their fingerprint is recorded, and the new one has got a new fingerprint, so he may be caught for his crime as well, which is done while he died.
This is also one very important issue which I overlooked.
This ethical issue. Now, Dr. Falksher, just quickly, I got this from one of our students, that how you know how to use leeches for counteracting and the venous congestion in the failing replant or failing flap or congestion. How you use it? What is your rationale?
In my training, we used only once or twice. We had to use these leeches. We took these leeches from Bhati Gate. There is one person who uses leeches for therapy of different skin conditions. So these are not medical grade leeches, and we have to be very careful for using that. But in certain problems, we cannot go for redo of the venous osmosis due to some issues. Then we can go for always for leeches therapy, but then we have to use certain antibiotics in order to prevent the the recipient from infection.
Okay, so thank you, Dr. Falakshay. We're just running out of time. I really want to thank you to taking your very obviously busy schedule for this nice and your very nice talk. Really, I will take.
Thank you very much for inviting us.
For all our residents for reading that. It's really a very nicely prepared topic for us. Professor Mostessan as well. As always, he has been very helpful in preparing our lectures and also in helping us in getting the information latest about flaps. And thanks to all other participants, all the attendees as well, who has been played their active role. I thank Dr. Ahmed Shahzad, who acted as a moderator for our conference. And really thanks all of you for really nice feedback and lecture. Thank you very much.
Thank you very much, Professor Asif, and thank you, Professor Falakshay. Thank you.